Um, what I'm today about is my approach to lesions. Going to be mainly X-ray focused. I wasn't sure where to start when I was approached with a bone lesion. So it's really important to have a systematic way that you look at bone lesions that will appear, because they will appear. I used to hope that they wouldn't appear, but better to take the approach that they're going to come, and you want to have something to say about them. And so when you think about how to make the correct diagnosis, we're going to talk about age. You want to know the age of the patient, the location. So for example, within a long bone, is it in the diaphysis, metaphysis, or the epiphysis? And is there a history of malignancy, right? It's so important. If you obviously have had a history of malignancy, then that would change the potential. When you're looking at an actual new bone lesion, I want you to start describing the density. And we're going to have a lot of practice cases at the end. So this is going to be a half didactic lecture, and then half we'll open it up to give people a chance to make the diagnosis. And what I teach my residents is to first look at the density. Is it sclerotic or is it lucent? Just start off very simple. What is the margin of the lesion? Is it well-defined or ill-defined? And is there periosteal reaction? If you can do these three things, you'll be able to say to yourself whether the lesion is benign appearing or malignant appearing. So in all the textbooks, we talk about aggressive versus non-aggressive. This is okay. And the reason that we're taught like this, and I was taught like this, then you have the term narrow versus wide zone of transition. Again, a term that I always found a little confusing. What does that mean, narrow? I think of a narrow, channel. Doesn't really make sense to me. So the salmon method is that I've kind of used, and I'm joking a little bit, is to try to look at a lesion and develop a sixth sense, develop a sense of, is this a benign or malignant process? We know, of course, there is going to be some overlap between benign and malignant, but in general, there's a lot of lesions that are just clearly benign and lesions that you should be concerned for malignant. They really do. So you might as well start using those terms now. When you look at the margin of the lesion, we want to, instead of using narrow versus wide zone, just more practical. Is it well-defined or ill-defined? Can you clearly see the margin of the lesion with the rest of the bone? Or does it kind of like blend in? You can't really see where it starts and stops. Well-defined will be more of a benign feature, whereas ill-defined is more of a malignant feature. So before we go into kind of like facing an unknown lesion, you do have to memorize a bunch of bone lesions. You have to just know a lot of bone. Now, in general, we have benign lesions, malignant lesions, and pseudolesions. Pseudolesions are not true neoplastic processes, they're not true growths, but there are spots on the bone that can look like a lesion, okay? And it's also very important to understand that those aren't lesions. I was taught once, and I found it very useful, instead of just memorizing a list of lesions in no particular order, I think it's important to break up lesions by tissue type. There aren't that many things within each tissue type that can occur in the bone. So first you want to identify the types and then learn the lesions within those types, and that'll be less for you to memorize. So first of all, you have osteoid or bone-producing lesions, right? You have cartilage lesions or chondroid lesions. This general category of fibroosseous lesions and cysts. So let's go through all of those lesions, and we're going to show multiple examples of them. Now, for this part of the talk, you're going to see benign diagnoses up high and malignant diagnoses below. The image on this particular case. So when we talk about osteoid-producing lesions, we're talking about lesions that produce bone. That's why they're sclerotic. You have benign lesions, osteoma. You've seen them all the time in the skull. We have osteoid osteoma, little tiny dot that we see. causes a ton of edema, pain. Enostosis or bone island, see it all the time, has spiculated margins, right? So those are benign osteoid producing lesions. Malignant osteoid lesions, of course, in pediatrics, the main one that we are worried about is osteosarcoma. It's a sarcoma that produces osteoid. And that's why in this example here, you can see there's a cloud-like ossification. And, and the bone defined. This is osteosarcoma. And of course, blastic metastases, so metastases that can produce osteoid. How about cartilage lesions or chondroid lesions? Same. This lesion I show is a very large version of it because it can kind of be a little bit scary to think, is this truly an enchondroma? But it actually is. It's a lesion within the canal, and it is lucent. If you see a lucent lesion in the canal in a small bone of the hand, most likely it's going to be enchondroma. And yes, they can be expansile, as you see here in this case. Osteochondroma has characteristics of a cartilage lesion and a bone lesion. So I'm showing you a very large example, but remember the classic description of cortical and medullary continuity of this lesion. It's one of the only lesions that causes a bony outpouching. Finds very particular appearance, and nothing else really looks quite like this. And at the cap, you can sometimes have this more sclerotic appearance. The cartilage cap is something that we can only see on MRI, and we'll talk about that later. But cartilage cap. Chondroma or periosteochondroma, I think of it as a cartilage lesion similar to an enchondroma, but it's on the surface of the bone rather than within the medullary canal. Notice how it produces very odd appearance. When you're looking at the x-ray, you just see something that looks like it's pushing into the bone and scalloping the underlying cortex, but not going all the way through. On MRI, you see a T2 bright lesion, very typical for a cartilage lesion, on the surface, embedded in the cortex. And the thought is that these lesions originate between the periosteal layer multiple locules, multiple compartments, like an aneurysm. That's why it's called aneurysmal bone cyst. We see another example here in the proximal fibula, where we have an expansion of the bone, and we go to the axial T2, and we see this very classic multiloculated fluid level lesion. This is what we call pseudo lesion. This is an important thing to realize in younger kids, especially. A lesion that is unnerving. You're going to be looking on the frontal, you see a lucent lesion in the metastasis. But when you go on the lateral, you can't really find it in the medullary space. You kind of wonder, where is this lesion? It's actually embedded in the cortex, this small little lucent area. And what this is sort of a tug lesion. It has a few different names. You'll hear cortical desmoid. I prefer the term avulsive cortical irregularity because cortical desmoid sounds like a tumor. This is not a tumor. It's thought to be a tug lesion of a gastrocnemius origin on the back of the cortex, and that's why I like the term avulsive cortical irregularity. The problem is when you see it on FOSS, it can look like a lucent lesion, and it's always in the same location. It is always in the posterior medial distal femoral metaphysis. This is another common pseudo lesion. I get called on this a few times a year. What is this rounded lesion here? Do we have to do anything? Remember that the ischiopubic synchondrosis is sort of a growth plate of the pelvis. When it is fusing, sometimes you get hyperostosis, a little bony rounded thing here. And if it's asymmetrical, that can be a bit unnerving for people to see. This is just a normal finding. This is an important pseudolesion to know about. It is known as avulsive adductor syndrome, or thigh splints. Remember that the adductor magnus muscle has a very broad and large attachment onto the medial femur. And in children that are doing a lot of physical activity, you can get a stress reaction or a stress fracture even of that proximal femoral diaphysis. The problem is that as radiologists, we don't like to see unexplained signal in the diaphysis in pediatrics because we get concerned for Ewing sarcoma. And that, unfortunately, is what this was called on the outside. So this patient actually came to biopsy, and you can see here on the pre-biopsy scout, we don't really see an actual lesion. The only thing we see is some smooth periosteal reaction. This was just a fracture that was healing. So remember, thigh splints. In the other category, I'd like you to remember Langerhans cell histiocytosis of bone, LCH. There's an older term, eosinophilic granuloma, or EG. Now we just say Langerhans cell histiocytosis. It's a very characteristic appearance of a punched out lytic lesion with a smooth periosteal reaction. Notice how it's not a very aggressive reaction. And then an MRI also has a very characteristic appearance where you have massive bone marrow edema around the lesion. This lesion is known to cause massive reaction. I think it was one of the two in my SAMET 4 that I remember of lesions that are extremely reactive. And giant cell tumor of bone is actually something we really don't see in pediatrics. It's usually in young adults, but I put it in here and because you'll occasionally see it depending on where your age cutoffs are. It's seen in closed growth plates. Now, those are lesions that you just need to know. And then what we're going to do now is talk about when you're faced with a lesion, what are the characteristics you need to describe? And that will help you get to the diagnosis. So first, you're going to look at a lesion and describe the density. Is this a lucent lesion or a osteotosclerotic producing lesion? First, I'd like you to just say if it's lucent on X-ray. What I find is that it's very tempting, and I've seen residents do this a lot, is to assume that something lucent is cystic. That may be the case. However, there are multiple solid lesions that are lucent. Lucent just implies that the X-ray beam is able to go through it with ease. It's not blocked by the X-ray beam. So under lucent, you have cysts, of course. You have unicameral bone cysts, aneurysmal bone cysts. But you do have solid lesions. You have lucent lesions that are NOF. We showed lucent bubbly cystic lesion. You have fibrous dysplasia, which has the classic ground glass density, but it's also lucent. But you do have these lytic destructive solid lesions. So in this example, we do have a giant cell tumor of bone, which is an end of bone lesion. And it would be false to say that this was cystic, right? Because this actually was a solid hypervascular lesion. So first just say lucent to yourself. Here's an example of fibrous dysplasia of a rib. So we have thickening of a rib. We have ground glass density, okay? And this was fibrous dysplasia of a rib, very common. This is a unicameral bone cyst. Notice how unicameral bone cyst is not expansile. It may fill the medullary space, but it's not expansile. The most common location for a simple bone cyst far and away is the proximal humeral diaphysis metaphysis. And so if you see a lucent lesion with a well-defined rim in the proximal humerus, think unicameral bone cyst. If you see something in the metaphysis, remember that in pediatrics, most of our infections are blood-borne, meaning it's hematogenous spread. You see a lucent lesion with a fading sclerotic rim, and this was osteomyelitis with a developing Brodie's abscess. Density of bone lesions, sclerotic. So if you see this, very obvious example of a bone-producing lesion, osteosarcoma here in the distal femur. Occasionally, Ewing sarcoma can be sclerotic, and occasionally osteosarcoma can be lytic. Sometimes fibrodysplasia can have more sclerosis in it, and osteodysteoma is your classic bone-producing benign lesion. What about the margin of the lesion? I like to use well-defined and ill-defined rather than narrow zone or wide zone. When I look at this lesion here, I see a bubbly, lucent lesion with a sclerotic rim. The body has been able to contain this process. That is a benign feature. It has low biologic activity. It is eccentrically located, touching a cortex, and it has a well-defined margin. So when you say to yourself, well-defined, I want you to say, this is a benign appearing lesion. This is another example of a non-ossifying fibroma. This lesion here is kind of ill-defined, right? We see this vague, lucent area of sclerosis. You might ask, well, is this osteomyelitis? This is a real case that I had, and I called the ED, and I said, is there any sign of infection? Is there a white count? Is there fever? No, 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 no. And then I saw, I have an ill-defined lesion and there's no history of infection. This ended up being a Burkitt lymphoma of bone. So when you hear yourself saying ill-defined, think malignant appearing, obviously realizing that occasionally there is overlap. What about periosteal reaction? We see this every single day in practice for fractures, right? If you have one line of smooth periosteal new bone, that's very common, a benign periosteal reaction. For malignant, you're going to have three patterns that you're going to look for. Lamellated or onion skinning. That means the body is desperately trying to contain this malignant process. It is laying down multiple layers periosteum to try to contain this malignant lesion. Codman's triangle is, again, it's trying to desperately contain this malignant tumor, but the tumor has exploded out into the soft tissues and broken through that immature periosteum, and that's why you get that Codman's triangle, the two ends of interrupted periosteal reaction. Sunburst is hair on end. We rarely see it, but that's another malignant reaction. So here's an example of onion skinning. We can't even see where the lesion is. It is so ill-defined. If you see onion skinning multiple layers, that tells you that the body is working overtime against this very biologically active lesion. Codman's triangle, here's an example of an osteosarcoma here. You have periosteum starting to work here, but then the extra osseous soft tissue has gone through and it is interrupted. And so that's a very malignant appearance. Sunburst, you have periosteal reaction that is perpendicular to the bone, looks like blades of grass. And so again, this is telling you that the body is trying to keep up with this highly biologic lesion. This is a malignant reaction. And finally, before we get into the cases, you're also going to say where a lesion is. So in pediatrics, I can't stress enough, if you see a lesion in the epiphysis or epiphyseal equivalent, which is basically an apophysis or these areas of bone that have similar differential diagnosis to epiphysis, you're going to say chondroblastoma, chondroblastoma, chondroblastoma. What are epiphyseal equivalents? There's many of them. You have the patella, the tarsal bones, the greater trochanter. These are similar to epiphyses, but they're not at the end of a long bone. They may be on the sides of the long bone. Like the greater trochanter, they could be within the foot, right? When you see a lesion in the metaphysis, you're going to want to know the history. Is there a sign of infection? Osteomyelitis loves the metaphysis in pediatrics. So if you see a lesion, you might think, is this an abscess? Of course, osteosarcoma also likes metaphysis as well. If you see a malignant appearing lesion in the diaphysis, Ewing sarcoma is what you're going to worry about. Okay. I am going to now open this up here. So I have my chat open. And what I'm going to ask you to do is not only just say the diagnosis, but we're going to try to use the Samet method here to describe this lesion. And I'm going to do this one first here, but you can say the answer. We have a lucent lesion, right? So we're going to do the density first. We have a lucent lesion with a well-defined rim, right? That tells you this is likely a benign lesion. On T2, it is very, very hyperintense, okay? So everyone knows this. I see in the chat, this is a simple bone cyst or unicameral bone cyst. Do people see what has happened to this patient? This weakens the bone, right? So this was a cross-country runner, and there is a stress fracture that has developed. Very good. We have another lucent lesion in the epiphysis. The lesion is, oops, went too fast. The lesion has a well-defined rim, which is a benign feature. Now, chondroblastoma is the answer. Someone said giant cell tumor of tendon, giant cell tumor. This is a younger patient. If you see open growth plates, then don't say giant cell tumor. Brody's abscess is most commonly in the metaphysis, actually. It is possible that you have it in the epiphysis, so that's okay. And by the way, there was a non-ossifying fibroma right here on the edge of the field view. This lesion has a ground glass density, very, very characteristic of this lesion. Everyone knows it. This is fibrous dysplasia. You guys are too smart. Now, this is more of a thinking case. So I want you to describe what kind of periosteal reaction this is. Is this benign or malignant? This is thick hyperostosis, benign appearance. It's not lamellated because I just see one thick area. There's not multiple lines, right? So you should say this looks benign, and you want to further investigate. I'm going to show you the CAT scan, and you see buried in the cortex is a lucent lesion with a little sclerotic dot. This is osteoid osteoma. Very good. This was a basketball player, had no antecedent pain, fell down a very mild fall. We have a lucent lesion with a well-defined rim. That's a benign feature. It's not very, very expansile. It's really just filling the medullary space. There is a pathologic fracture. And we see this thing here. What is this called that helps us tell us that this is a cystic lesion? There's this little thing here floating at the bottom. Fallen fragment sign. Excellent. So this is a simple bone cyst with a fallen fragment sign, very common in the proximal humerus. This is a sclerotic lesion, so we've talked about the density. And now we're going to talk about the margin. The margin is not really well defined. We see areas going into the epiphysis, kind of looks blurry on the side. This is very concerning. This is osteosarcoma. Okay? So someone said Brody's abscess. That would not look like a dense sclerotic lesion. And I want to make the point that this didn't have periosteal reaction, so don't let that dissuade you. We have a saying, a three-legged dog is still a dog. I like that. Don't wait for all of the findings, A, B, C, to diagnose osteosarcoma. And yes, it has spread across the growth plate into the epiphysis. So don't wait for the periosteal reaction. You may not see it. This was a patient with dull pain for about 2 months. What we're seeing here is a lucent lesion with ill-defined margins, very ill-defined margins. So you should say to yourself, this is a malignant appearing lesion. And then when you say, where is it? It's in the diaphysis. You want to say Ewing sarcoma. So this was, unfortunately, a Ewing sarcoma. Ignore this little round circle here, but judge it based on the other part of this. We have a sclerotic lesion, so we talked about the density, and the margins are ill-defined. The margins are ill-defined. So ill-defined means this is malignant appearing. This patient had no history of infection. You want to be concerned for osteosarcoma. Chronic osteomyelitis is not a bad thought, but you want to be very careful before you make the diagnosis. You want to have multiple prior films showing osteomyelitis. You want to call the clinical service before you say that. And so this was actually osteosarcoma. This is a lesion that, as I was saying, has a very unique appearance. It is a bony outpouching. It's a bony outpouching, and it has corticomedullary continuity, very smooth, very smooth. I will tell you that on the MR, there was no mass associated with this, and it just had a very thin cartilage cap. Okay, most of you got it. This is osteochondroma. Enchondroma, remember, is a lesion that's in the medullary space, does not have a bony outpouching. Now, this is tricky because some of you did say I've also cortical irregularity, cortical desmoid. That is not a bad thought, but it's usually more of a lucent lesion, doesn't have a bony outpouching. Paraosteosarcoma is something you definitely want to consider. That's okay. Usually it would be like very dense, like a sclerotic white ball kind of sitting here, and not the corticomedullary continuity, but you can go to advanced imaging to help that. BPOP is, someone put BPOP and bizarre osteochondromatous proliferation, or Nora's lesion. That's usually in the hands and feet, and it's just like a little osteochondromatous lesion, not really like this big. That's not a bad thought as well, though. This is a very thought-provoking case. I like to show this case here, where you need to say where is the lesion and get your differential. So I see people are already getting it. We have a lesion in the greater trochanter. So first to realize there's a lesion in the greater trochanter with massive surrounding edema. So you have a lesion that's in an apophysis, which is an epiphyseal equivalent. And we talked about epiphyseal equivalents being the same as the epiphysis. We go to the CAT scan, we see little tiny punctate calcifications. This is chondroblastoma. You guys are awesome. And I love this case for my residents because it makes them think about where this lesion is. This patient came to the ED with swelling of the ankle, fever, and bacteremia. Someone found a lesion here in the metaphysis. There's periosteal reaction. And whenever you hear yourself saying lesion in the metaphysis, think of abscess. So this was a Brody's abscess because we have the history that there was infection. This is a hard one, right? So we look at this and we say there's a sclerotic and lucent lesion. It's very ill-defined. When you see an ill-defined lesion, you want to have your antenna up and think malignant. Malignant until proven otherwise, right? So we have a lesion that looks malignant. As part of the exercise here, not even just making the diagnosis, is for you guys to look at this and say, this is a malignant appearing lesion. We don't have periosteal reaction, but we know this is something malignant. And this ended up being an osteosarcoma, but just to show you that this is a malignant lesion, even if you don't know what it is, you don't want to let it go. DDX for tumors with marrow edema, someone asks. Langerhans histiocytosis, chondroblastoma, osteoid osteoma, and infection. Those are the ones I always think about. Here's a lucent lesion with a well-defined margin. So I'm thinking benign, and I'm thinking epiphysis. Epiphysis, benign. Remember what we talked about? This is chondroblastoma again. This was a 13-year-old who came in with pelvic pain. There's 2 lesions on this film. So we see a destructive lucent lesion here in the pubic bone. That alone is very concerning, right? You don't have well-defined margins. It's destructive and lucent. We would be worried about Ewing sarcoma. There's another lesion here. It's a lucent lesion with a more well-defined margin and sclerotic rim. So this is a bit confusing, right? And we don't necessarily know what it is right away. We do want to worry about Ewing's, but this was not Ewing's. Orthopedic surgeon called me and said the family is very distraught. Is there anything else this could possibly be? And I said, well, if you have 2 lesions, if it's more like this benign one, think about Langerhans cell histiocytosis. And this was just LCH with multiple lesions. LCH can look malignant or aggressive on X-ray, even on MR. It can have tons of reaction, and sometimes you may not be able to differentiate between Ewing's. This, in fact, had a soft tissue mass, and so that was even more concerning. Malignant giant cell tumor of bone is an extremely rare lesion. I've only seen maybe 1 case in my entire career where you have mets to the lungs. Again, giant cell tumor of bone is usually something you only see above like 20. So this was like a 13-year-old. There is a lesion in the iliac wing and a lesion in the pubic bone right here. Now we're going to get into some more challenging cases and think about lesions with multiple lesions, okay? So we have multiple lesions that all look the same. They are basically bony outpouchings, right? Bony outpouchings in the metaphysis of all the visualized metaphyses. This was multiple hereditary exostosis. Excellent. There is a very small risk of malignancy, and we want to follow them for any growth. They can grow throughout skeletal maturity. After skeletal maturity, they really shouldn't grow or cause new pain. This is one leg. There was a leg length discrepancy. This next case, we have a lesion that's kind of a streak-like lesion with multiple little chondroid, little punctate calcifications. This other like paintbrush streak lesion in this metaphysis. So you have a leg length discrepancy with multiple lucent lesions, some with chondroid matrix. Think of your lesions, your polyastotic cases. So you have multiple lesions here. This was Olier, which is enchondromatosis. Some people said chondrosarcoma. Remember, that is extremely rare in pediatrics. I want you to look at this and think multiple lesions, leg length discrepancy, chondroid matrix, Olier. I love this case. This is a lesion where you have multiple intra-articular bony outpouchings. Intra-articular bony outpouchings. And they've broken off into the joint. This is Trevor's disease. Very good. You guys are unbelievable. I love it. So dysplasia epiphysealis hemimelica. It is kind of similar to, not exactly, but to MHE, but instead of it being in the metaphysis, it's actually in the joint. And people talk about these osteochondromatous nodules that you have in the joint. This was a 7-year-old that came with from the outside hospital with just very limited range of motion in the elbow. She carried a diagnosis of arthritis. People couldn't figure out what was going on. When you look at the scan, though, first you see mass, but then you see, what is this little rounded thing in here? And on CT, you have a sclerotic area inside a lucent area. And so there is a bit of a differential, yes. But this was an osteodysteoma intra-articular. When you have osteodystiomas that are intra-articular, they can be very troubling to diagnose because osteodysteoma will do the same thing it does in any location, however, which is massive reaction. But when you're in the midshaft, it will cause hyperostosis, edema, periosteal in the bone. When you're in the joint just reacts to however it knows how to react. And inside of a joint, what do joints do? They do joint effusion, synovitis. And so it's a fooler. Someone said osteomyelitis with sequestrum. It's not a bad thought at all. Could definitely be that as well. But this ended up not having any sign of infection. This was an intra-articular OO. This is a lesion that, this is the largest one I've ever seen of this. It has a ground glass density, right? So people are saying fibrous dysplasia, but remember that it is in the anterior tibial cortex, very classic location for this particular lesion. And you see on the CAT scan, it's actually an intracortical lesion. It's an intracortical lesion because the medullary space is just this tiny little thing back here. And so this is basically fibrous dysplasia in a cortex, otherwise known as osteofibrous dysplasia. And this was the largest osteofibrous dysplasia I had ever seen. Adamantinoma is a differential diagnosis, as was said in here as well. Usually seen in older patients, but definitely a reasonable differential. This was osteofibrous dysplasia. It loves the anterior tibial cortex. And it is, instead of it being in the medullary space, it's in the cortex. This is a lesion someone detected on a radiograph. It's in the superolateral aspect of the patella, and it has a very funny, like, invagination from the subchondral bone, right? And so you might think, could this be a chondroblastoma because it's an epiphyseal lesion? But this invagination is very characteristic. Yes, this is dorsal defect of the patella, and as all patellar variants, it loves the superolateral aspect of the patella, I find, for patellar variants, bipartite patella. So this is just a developmental thing, and known as dorsal defect of the patella. And lastly, this case here is an expansile lesion, multiple fluid levels. This was aneurysmal bone cyst. There's another lesion here that has nothing to do with this. And this is a non-ossified from the tibia over here. So someone said telangiectatic osteosarcoma. It's very reasonable. That is what we always worry about when we see an aneurysmal bone cyst, that it can have a secondary aneurysmal bone cyst. As you scroll through this scan on the post-contrast, you would look for any solid areas of enhancement rather than just rim and septal enhancement. And in this case, it just had rim and septal enhancement. There was no actual soft tissue lesion. And so we were comfortable just calling this a primary aneurysmal bone cyst. The tibial lesion was just a small non-ossifying fibroma here that is in the stage of healing because it is sclerotic. Wonderful. You guys are too smart. I love it. And now I can open it up to questions on the entire talk. Thank you so much for listening.
Thank you, Jonathan. That was awesome. And thank you for teaching us the Sambit method. That was so good. I have a few questions here on the Q&A box. I'll just read them out for you. So the first question is, in osteochondroma, sometimes we see cartilage signal within the bony portion of the exophytic osteochondroma, but the surface cartilage lining is thin. Is that a suspicious sign for malignant transformation?
Okay, very good question. No, it is not suspicious. If you read the article, sometimes you have the surface cap, but then it has like little crevasses, little little downward spikes into the bone. That's totally fine. People talk about that, and actually, you're not supposed to include that in your measurement of the cap, um, because that can overestimate the cap. So you often see that, and it doesn't mean that it's malignant. Usually, when you worry is when you have the cap is more than 2 to 2.5 centimeters. Some people will even say less. The cap gets very thick, and that's when you worry about malignant transformation. And if you have a soft tissue mass that's coming from it, but yeah, just that finding alone, it's not suspicious.
Okay, thank you for that. The next question is, can we differentiate a unicameral bone cyst complicated with fracture from an aneurysmal bone cyst? On MR, both will show fluid levels.
Very good question. That can be hard, and sometimes you can't tell. I think few things. One is aneurysmal bone cyst will be very expansile. The whole outer part of the bone, as you saw, is ballooned out. Whereas unicameral bone cyst, you might have a fracture, but it's not going. The bone, as you saw in the other case, is still the normal width of the bone. Yes, both can have fluid levels, but remember that unicameral bone cyst is usually unilocular, may have like one septation. Aneurysmal bone cyst has numerous septations. There's multiple little tiny locules within it. So those are some things you can use.
Awesome, thank you. How to differentiate a periosteal from a parosteal osteosarcoma?
So periosteal versus parosteal. First of all, in pediatrics, we don't really see these as often. Only seen a few of these. Parosteal, in my experience, first of all, is more benign, and that not benign, but that's the best one. That's the least aggressive. And when you do an MR, usually parosteal is more densely sclerotic because it's more differentiated. So you'll see a white golf ball like looking area of ossification, and it won't actually invade into the medullary space. When you do an MR, it just looks like a big white thing or a big dark thing sitting on the cortex. Whereas periosteal osteosarcoma is a little bit more of an aggressive surface osteosarcoma. And when you do an MR, that might actually invade into the medullary space. So the most important thing on MR is seeing that T1 medullary space, the fatty canal. If it's not invading into the canal, it's more benign and it's more likely parosteal.
So we have someone asking for the differentials for metaphyseal lesions. I think you did show it at the start of the talk.
Yes. So I always want to know about infection because osteomyelitis loves the metaphysis. It goes right to the growth plate, which is the area of very high blood flow. So I think of infection and development of Brody's abscess. Osteosarcoma would be a sclerotic lesion in the metaphysis as well. Non-ossifying fibroma is a bit higher in the metadiaphysis, is a good differential for a lesion that's touching the cortex, bubbly, lucent lesion there. And you can have other lesions, metastases. But those are kind of the main ones.
So someone's asking how to differentiate between Ewing's and an LCH. I think
right.
that.
Yeah, so LCH I think is an extremely reactive lesion. It's a very inflammatory lesion. It can actually have a soft tissue mass, which can be confusing for Ewing's. Ewing's doesn't usually have like that much edema. In fact, if a bone lesion has a massive edema around it, it's actually less likely to be a malignant lesion. LCH, usually the periosteal reaction is not going to be lamellated. You don't really have that reaction. Usually, most of the cases of LCH that have periosteal reaction are going to be smooth, benign appearing reaction, whereas Ewing's would not. And also, by the way, when you look at LCH, and you can go back to the talk, when you look at LCH, for example, in a long bone, you have the classic punched out lytic lesion, which is very atypical compared to Ewing's. So I'll show you. So if you look at this lesion here, it's in the diaphysis, so you might be concerned for Ewing's. but you see how it has a very well-defined margin. Ewing's would never have a well-defined margin like this. This punched out lytic lesion with a well-defined margin and smooth benign reaction. This is LCH and not Ewing sarcoma. So that's one example right here where you would not worry about Ewing sarcoma. It wouldn't look like this. It would be that permeative look, and it would have probably onion skinning. It would never have a smooth reaction.
Okay. Can you show us case 9 again? Can it be an off or a CMF? I don't remember this case.
Okay, so is this the case? Because
Yes, looks, but yeah, I don't get the question then.
this I may be on the wrong case, but this patient I think just coincidentally had a small little NOF here. That's why I was saying just ignore this little finding here. This lesion here is a very ill-defined sclerotic lesion, and so that's not what a NOF would look like. NOF is going to be a bubbly, lucent lesion with sclerotic rim. So this is an osteoid-producing lesion that's ill-defined. You hear yourself saying ill-defined, and you want to think malignant.
What's the difference between an intra-articular osteoid osteoma and button sequestrum?
Very good. That's hard because they both they both can be like little tiny white sclerotic dots with surrounding reaction. First of all, that is a tricky question. Intra-articular osteosteoma, we just had a case. It's not necessarily like centered in the medullary space. Most osteosteomas are basically very close to the cortex. They can be superficial to the cortex, they can be within the cortex, or just deep to the cortex in the endosteal region. You can have intramedullary osteosteoma, but it's much less common. Bony sequestrum, I guess the ones that I've seen are usually, I guess they can be in a variety of different areas, but they often have, it's not like necessarily just like a little round calcification. It often has like a little, like almost looks like a little splinter, a little spike of linear thing. They have, they might have other signs of infection too. They might have like a cloaca or tract coming out of the cortex showing inflammatory reaction, whereas osteostoma wouldn't have any of those findings. And the history helps too, right? You have, right, like you have infection that they've tried to treat, they couldn't treat it very well, you've already been on antibiotics, and you develop this piece of dead bone. Whereas osteoblast, you're going to have no history of infection, right? It's going to be this.
I think I missed a question. Someone's asking the difference between an osteochondroma and exostosis, but I guess
so osteochondroma and exostosis, very similar terms. Exostosis is kind of the more umbrella, like larger category. Osteochondroma is a kind of exostosis. Osteochondroma is a neoplasm that has a cartilage cap. There's genes associated with osteochondroma. Exostosis is just a bony spur. So you see in the toe in adults, the turret exostosis. It just is saying there's a bony outpouching, but it's not necessarily a lesion with a cartilage cap. So all osteochondromas are exostoses, but not all exostoses are osteochondromas.
got it. How do we distinguish septic arthritis from osteomyelitis?
Well, septic arthritis is an infection of the joint, right? Of the joint fluid, whereas osteomyelitis is an infection of the bone. So they're two different areas of infection.
Can ABC cross the physis?
Can ABC cross the physis? I think so, yes. I think I've seen a few cases of that, yeah. As it gets bigger and bigger, it can cause problems.
Okay. Are there any characteristic findings of disuse arthropathy versus celiac arthropathy? I'm not sure what that.
So that's a very challenging diagnosis, where you need the clinical, and I think you're referring to also um, complex regional pain syndrome. I think sometimes you can just get like little abnormal signal in the cortex. You'll have abnormal, kind of unexplained marrow edema in multiple bones, and then you'll have a history of surgery on that side or whatnot. That's a very challenging diagnosis, and it's often a clinical diagnosis as well.
Can you please explain how to diagnose a chondroma intracortical lesion?
So chondroma, or really more commonly we talk about periosteal or juxtacortical chondroma, and the lesion is it's very interesting because it's between the cortex. It's not intracortical. It's between the periosteum and the cortex. So that's why it causes this scalloping, a very characteristic scalloping appearance onto the cortex. And I find that's a very unique appearance that you can look for. So if you look here, because of this lesion, it's pushing down onto the bone but not invading it, and it causes rough surface. And so it's not intracortical, but it's basically eroding into, it's a pressure erosion. And chondroma is just a lesion in the medullary space.
So, like Dr. Samit, in India, most of the patients pay from their pocket for imaging. So we have one attendee asking what is the most stringent indication for MR in general for tumors because of the cost.
Okay, good question. So definitely X-ray is the best to help first evaluate lesion. I think if you're really going to be cost effective, you theoretically could you might even biopsy a lesion sometimes. Once you know it's malignant, then you do an MR and you can see the invasion. So for example, for osteosarcoma, you definitely want to do an MR because you want to see, is there skip lesions, right, in the same bone. You need to know that in order to know where to actually make the resection. Because if you have a lesion in the proximal metaphysis, you could have a skip lesion a little bit below, and if you do the amputation at the wrong level, you're still going to have tumor there. So if you're being very cost effective, you definitely want to do it for osteosarcoma. And then it also can tell you if there's neurovascular invasion as well, which vessels are being compromised, things like that. So for malignant lesions, you definitely want to do MR. For benign lesions, you probably could skip the MR if you feel confident on the X-ray. There's one when we talked about lucent lesions, whether they could be cystic or solid. That I find MR is very helpful. If you're not sure if it's cystic or solid, MR is very useful because you can see if it's a cystic lesion, it's going to have T2 bright rim enhancing, whereas if it's a solid lesion, of course, it's going to have some solid enhancement. And so that's another example of where MR is very useful, is cystic versus solid. So that's a few things that you could do.
Awesome. Jonathan, we have a lot of questions coming in. Do you mind continuing or?
Yeah, we can continue. I'll answer all the questions.
Awesome. Good. So the next question is septae enhance in which lesions?
Right. So anything cystic is going to have a wall and might have septation. So for all cystic lesions, right, you're going to have rim enhancement and septal enhancement. So that's just okay to expect that. And that doesn't mean that it's malignant.
All right. Do metastatic bone lesions have periosteal reaction?
It may or may not. Some of these lesions, it depends, I think, how close it is to the cortex to irritate the cortex. So you may or may not have that. So don't let that dissuade you. If you see something that looks concerning, then don't wait to see periosteal reaction.
Do you, this is my question. I recently saw this child with humerus Ewing's but had mets in the distal femur. We couldn't do anything to prove that it was metastatic. There were just 3 lesions in the distal metaphysis. But yeah, I mean, given that this child had Ewing's, we didn't really have anything else to go by, and biopsy was too morbid for them. Do you have anything else that you would keep in mind in children like that? I know it's very vague without an image, but
No, I think you're right. I mean, if you have a malignant diagnosis and you see other bone lesions that look malignant, it depend. If they look aggressive as well, the other ones, then yes, I think I have seen Ewings go from one bone to the other bone for sure. Mets can definitely go to other bones in Ewings. You always want to be careful not to assume that something is a metastasis. So if it looks like an NOF in the femur, then you wouldn't call it a met, right? But it sounds like in your case, these were very concerning looking as well.
yes.
And so I have seen that, yes.
Okay, got it. Thank you. Okay, so the next question is, if the clinical presentation is somewhat equivocal, what further problem-solving tool do you suggest for a radiological differential of Brody's in the metaphysis, and what path of follow-up will help to clarify?
So if you see a lucent lesion in the metaphysis and the kid has a sign of infection, you can do an MR, and the MR will have very characteristic appearance of osteomyelitis. You're going to have a lot of edema, enhancement. The Brody's abscess, because it's a cavity, will have central non-enhancement and peripheral rim enhancement, right? And then if you have diffusion-weighted imaging, you might have restricted diffusion within the side of the abscess. And usually if you have a Brody's abscess, it's a very, the infection has had time to fester. So you're going to have other findings of osteo, right? You're going to have really bad signal in the metaphysis, suggestive osteomyelitis, ton of edema. You might also have a subperiosteal abscess, things like that to help push you to abscess versus a different kind of lesion. If you have an abscess in the setting of infection, usually orthopedics or IR will definitely want to put a needle in that, and they will get pus out of it, and they can send to path, and they will send for microbiology to confirm infection. What you might be alluding to is that you do occasionally have cases where there can be foolers, right? So I have seen cases of chondroblastoma that are more, they can have fluid levels, they can be cystic a little bit, and when you go in, you don't see infection, they scrape the lining of the cyst, and they find that it was one little chondroblastoma cell. So you can have that, but again, usually the history is very helpful in these cases.
So why does a hemangioma, I guess intraosseous hemangioma, show head-on-end type malignant reaction, although it is benign?
Well, in the extremities and pelvis, I don't see hair on end.
Right.
I actually think it doesn't have that in my experience. Basically, it looks like a lucent lesion with internal fat sometimes, and it has that spoke wheel appearance of thick trabecular markings. I think what you may be referring to is sometimes in those calvarial hemangiomas, they can look kind of like aggressive, if that's what you're referring to. But in long bones and pelvis, it doesn't have that type of reaction in my experience.
Got it. Would you, I'm going to paraphrase this question, need to do an ultrasound for an exostosis if MR is not possible? Not really. Right?
You could do an ultrasound, yes, because actually, if you do an ultrasound, you can see the cartilage cap actually very well. It will be a hypoechoic area. We see it all the time in like rib lesions when children come with bony bumps, they feel bumps. You do an ultrasound and you see the rib kind of come up, and you see like a little hypoechoic. You have to be looking very carefully for it. but you can see a hypoechoic cap, very smooth, and you can actually measure the cap. So you can do ultrasound, yes. The problem is if it's very deep, you wouldn't be able to see it.
Right. Does the age of the child change the location of an osteomyelitis? Um, I don't know how to make sense of it.
Well, yes, yes, yes. That is it does change. So if you have a newborn, right? If you have a neonate, the transphyseal arteries are still present, and so that's the theory of why babies, like infants, can get osteomyelitis more so in the epiphysis, because the infection goes to the metaphysis, spreads through the transphyseal arteries across the growth plate into the epiphysis. And so as you get older, those transphyseal vessels recede. And so that's why you usually have infection more in the metaphysis. So,
Cool. How do we distinguish between blastic lesion and sclerotic lesion?
that's pretty much the same thing. I mean, blastic just means like bone producing. It has a malignant kind of, it's when you say blastic, you're worried about a malignant lesion. Sclerotic doesn't necessarily mean malignant; just means that it has osteoproducing. You're basically just saying that it has osteoid production. That's all that means. It's the same thing.
What's the differential for chondroma?
So for enchondroma or periosteochondroma, so I think the differential for cartilage lesions, someone had mentioned earlier about chondromyxoid fibroma, which is a very rare lesion. That's another cartilage lesion that could be a fuller for enchondroma. It really depends. You can have sometimes when you just see a T2 bright lesion on MR, you can be confused. You need to give post contrast. You might have LCH. You might have. It really depends on exactly what it looks like, but you can have things that can tease it out. I'm not sure the exact question, but there's some things that can overlap, but you can use multiple imaging modalities. If you see chondroid calcification, that pushes you to a chondroid lesion, whereas if you don't, it will push you to something else.
How common or uncommon are skip lesions in osteosarcoma in your experience?
Not that common. I think it's like I think the literature says something like I don't know, like 10% or something, 12%. Is something we always worry about. Um, but we most of the cases we see in my anecdotal experience probably don't have skip lesions. They usually diagnose at they biopsy, and then they do like 10 weeks of neoadjuvant chemotherapy, and then they rescan. Um, and occasionally you see it, but you definitely want to know it because surgeon will get very upset if he cuts in the wrong place. That's for sure.
So many non-cartilaginous lesions are bright on MR. What
That I like to use is the margin of a chondroid lesion on MRI. Chondroid lesions and chondromas in particular have, if you look at it very carefully and you zoom in on it, will have a microlobulated margin, not a smooth margin, not a round margin. It'll have a little bit of a microlobulated margin. That's very characteristic for a chondroid type lesion. And so I like that in order to push me to say something is a chondroid lesion. If you have like a little bone cyst, it's not going to have that little microlobulated margin.
What's the difference between spina ventosa and expansile in chondroma?
I actually don't know what spina ventosa is.
TB dactylitis. Like I think it's not that commonly we see it. I mean, we see TB in adults more than in children, at least in India. But yeah, we do see this expansile kind of sclerotic lesion in the fingers, the phalanges, um, and
A-
it's called spina ventosa. But yeah, not that common.
and it's a finding of TB, you said?
Yes, yes, tuberculosis, osteomyelitis.
Yeah. Um, I haven't really seen that, to be honest with you, but I think that enchondromas usually are very lucent, so they're not sclerotic. They are usually lucent lesions in the fingers, so that will be the way to tell.
Have you come across a brown tumor and tubercular osteomyelitis in children?
We occasionally have had brown tumors in someone who's hyperparathyroid. We have had a few cases. We have had a few cases of tuberculous osteomyelitis, which we've had cases where it like presents as a septic joint, and it's massive joint effusion, and um, but not very many. Um, and brown tumor is not that common, honestly, that we've seen.
Got it. Which pediatric primary tumor can give plastic mets?
I think probably a few of them. It really depends on if they've been treated or not. I think some of the neuroblastoma mets can be blastic. Um, Osteosarcoma, the variants of renal cancers. The Wilms tumor usually goes to lungs, but there's like a clear cell um, that can cause sclerotic mets.
Okay. Do you always use DWI in your MR protocol for a bone lesion?
Yes. So in our tumor protocol, we use diffusion weighted imaging. Just put it in there. Sometimes you don't use it, but we just have it in there just in case you do need it. And you can get an ADC value, which is very nice to document the number pre and post treatment. So if you have restricted diffusion, it's more concerning for a malignant lesion. And if you follow it over time, the ADC value will improve, will increase. And so studies have shown that, like with osteosarcoma, you can use the ADC value to help monitor treatment.
Is osteosarcoma a mimicker of chronic osteomyelitis, and how do you differentiate barring the history?
So I feel like I haven't seen that many cases of that. I know that is something that is a reported mimicker. I find that it depends if you're only doing X-ray alone or if you have MR. Because if you see an ill-defined sclerotic lesion and you're going between chronic osteo and osteosarcoma, I would recommend an MR. And on MR, it's very easy to tell the difference. Because on MR, usually there's like a marrow replacing lesion with a soft tissue mass, whereas osteo wouldn't have that. And so I think MR is really how you tell the difference.
At times, obvious clinical diagnosis on X-ray doesn't match the MR biopsy histopath diagnosis. Is histopathological evaluations of bone tumors tricky or not easy? Can they be biased towards MR diagnosis in your experience?
Definitely tricky. I think I work closely with our pathologists. They for bone lesions, I think, need our help more than in other tissues, and so they're commonly asking me what I think the bone lesion looks like, and so you have to work together with them because they can get confused on their sample, which might be a small little sample of a lesion. So they say that the radiologic appearance of bone lesions is actually very important for them when they're kind of considering the diagnoses. I think the pathologists they're really good with benign and malignant, but when you deal with some benign lesions, it's very hard for them to kind of come down like really hard on a certain lesion, so that the imaging appearance is very important. So yeah, I think it's a discussion that you have to have.
I think I'm gonna take the last question from the chat box. How do you differentiate a high-grade osteosarcoma and a telangiectatic osteosarcoma, since both have fluid flow levels and solid tissue and thick septations?
Sorry, I misunderstood the question. How do you differentiate high-grade osteosarcoma from telangiectatic osteosarcoma?
Right.
One, it doesn't really matter because, first of all, telangiectatic osteosarcoma is a high-grade osteosarcoma. They're both osteosarcomas. One just happens to bleed more. And it used to be a theory that they were more aggressive, but I think that's actually shown not to be components in them. Question is, when you're dealing with an aneurysmal bone cyst, how can you make sure that you're not dealing with an osteosarcoma, telangiectatic? And that's what people more get worried about, because you see a large lesion that there is a second and you don't have benign malignant secondary ABCs. So you can have a benign lesion that produces ABC and a malignant lesion that produces ABC. Malignant lesion would be a telangiectatic osteosarcoma, but chondroblastoma, Janssen-Smith bone, both of those can have ABC components. So if you have a solid nodule within that, you need to biopsy it. And telangiectatic osteosarcoma versus regular high-grade osteosarcoma, usually sarcoma that we see doesn't have fluid levels, so that would be the difference.